good afternoon. My name is Nick James. It's my pleasure to welcome you to this eCancer session live from the ESMO meeting in Barcelona. I'm joined here by Nicholas Mottet, who chairs the EAU Guidelines Committee, and a very prominent urologist, to discuss the data presented in the various prostate cancer sessions here.
Correct. So as you know, regarding guidelines, there has been a major issue with the androgen-sensitive metastatic disease, where with an endless discussion is high volume, low volume, high risk, low risk. And in the guidelines, we said from the very beginning that it's purely subgroup analysis. We had to be very careful. I heard that there was a little bit change at ESMO.
Yes, so obviously this has been a very live controversy, and we've always been very pleased actually the EAU took the same line as the STAMPEDE group, which was that we didn't see a volume effect in the data that we had. But the specific thing we hadn't done was split our patients by the criteria that they used in CHARTED, high volume, low volume, driven by number of metastases and visceral metastases. And so this is a retrospective analysis, of course, but we centrally pulled out around 90% of the scans, and maybe 80% of the scans, centrally reviewed them and classified the men into high or low risk. And basically about 45% are low volume, 55% are high volume using the CHARTED criteria. The other thing that I would highlight here is that in CHARTED, a very high proportion of the low volume patients were relapsed after prior therapy, and the same in GETUC 15, which was a negative trial but with a trend towards a positive result that was previously reported. Whereas in contrast in STAMPEDE, around 95% of the men in both the high and the low volume groups are de novo. So that's, I think, an important difference. So what the CHARTED group have previously reported and kept on stressing is that there didn't appear to be a survival benefit in the low volume patients, only in the high volume patients. And we have always taken the same view that you just put, which is this was an underpowered subgroup analysis, and it really didn't fit with, there wasn't any biological reason why, apart from anything else that we could see. So we were very keen to do this subgroup analysis, and we coupled it with a long-term follow-up, so the follow-up is more mature. So in terms of the follow-up for the whole cohort, the original result holds true. So docetaxel improves survival, improves failure-free survival, improves all the other endpoints. Yeah. So unsurprisingly, what we reported is correct, or is consistent. And then if we split it by high and low volume, what we see is that there is a survival advantage in both low and high volume patients. And actually the absolute magnitude of benefit is bigger in low volume. So it goes from it's about a 15% absolute gain at 5 years in low volume, a 10% absolute gain from about 25 to 35% at 5 years for the high volume patients. So depriving low volume patients of chemotherapy, you're depriving them of a survival advantage at 5 years of 15%, which we think is very important. So in the discussion, so the thing that we drew out was around the differences not between high and low volume, it's that low volume relapsing patients are probably different to all of the other groups. And your fellow countryman Karim Fizazi, discussing it, essentially agreed with that view.
Well, that's such a surprise. First thing, it's very reassuring that we were correct. That's an issue that when you interpret trials, you have to be very careful about subgroup analysis, but it was not pre-planned. And we try to insist on that. That's why for EA guidelines, for example, we accept the subgroup analysis for radiotherapy to the primary when they have M1 disease, because the trial was powered for such a subgroup analysis, but it was not the case for all the others. And I remember several talks by especially Susan Alabi saying, be very careful, subgroup analysis is the best way to lie. Yes. Not on purpose, but to find something just by chance. So we have to be very, very careful about subgroup analysis. It's very reassuring. I completely buy the fact that relapse and newly diagnosed are different, but in fact, that's common sense. If you relapse, you're followed very correctly. If you relapse 1 year after local treatment, come on, you were already metastatic before. The difference and probably are the same. But it's against interpretation of data.
It is, and I think the other thing about the relapsing patients is that, because it relates to the non-metastatic CRPC trials, is that the trend in the UK in particular is that we are PET scanning these patients after surgery or radiotherapy. You pick up relapses early, and so it completely alters the landscape, rightly or wrongly. We're not putting patients on ADT for a rising PSA only. We're at the very least having PET detected metastases, if not actually detected metastases on, if you like, on CT and bone scan. I'm sensing your skepticism here. So we don't, which is why we have such a low proportion of relapsed patients in our metastatic STAMPEDE population, because we're managing these patients rather differently. And I mean, obviously that's a separate issue around the role of PET in detecting relapse versus CT, bone scan, whatever.
But then if you use that kind of imaging modality for relapse, what you're doing is a major lead time bias compared to bone and CT scan. So is the lead time bias associated with a prolonged survival, not just lead time, but the prolonged survival? Yes or no, nobody knows.
I think the thing that the early detection allows us to do, because one of the things I'm increasingly concerned about is that when we set up STAMPEDE, the average survival with metastatic prostate cancer was 3 years. If you look at the low volume metastatic patients that we've just reported results on, if they get docetaxel, we're looking at a 5-year survival of 80%. So these men are looking at very long durations of ADT. So I think we need to look for ways to not put people on ADT for very long periods of time. So one of the concerns I have with the non-metastatic CRPC trials is these men have already been on ADT for a while, and then you're intensifying it before they've even got any metastases. And so I think we're going to be stacking up a lot of bone problems, heart problems, dementia, goodness knows what, because we know all these things are associated with ADT, and we're shoving the duration of exposure up. The thing about doing the PET scan is that we can give targeted radiotherapy and no long-term ADT to these patients. So it feels like the right thing to do, and I know you're going to tell me that I have no evidence to support it.
No, I agree with that. It might be the right thing to do. You have to be, again, I'm biased because of guidelines, but we have to be very careful. You can do it. It's not because we can do it that we have to do it. We can irradiate 1 or 2 single spots, that for sure. The toxicity is absolutely acceptable, no question. The question is, so what? Does it improve anything? Nobody knows. At the same time, there's a very strong and clear evidence that these patients need immediate ADT, not at all. Back to guidelines, salvage ADT at relapse should be reserved for those with the highest doubling time, with the shortest doubling time, the highest risk. And that's far away from being the majority. It's mainly the minority. So it's an over-treatment that leads to a non-metastatic CRPC.
Absolutely, and we lack data on this.
Yeah, exactly.
Yeah, I think the other, for me, interesting data which we were discussing was the data presented in the prostate session on Friday around adjuvant versus salvage radiotherapy. So, there were data from 3 trials presented. The Radicals trial, Chris Parker presented, and this is around 1,200 men randomized to adjuvant or salvage radiotherapy with high-risk features, so positive margins, positive nodes, things like that. The results were very reassuring. Firstly, didn't matter what you did, very few of these men had died, is the first thing. So it shows we don't need to rush to do anything, because even the 10-year metastatic rate is probably less than 5% in these. But the second thing was that in the Radicals trial, only around 1/3 of men had had salvage treatment, whereas obviously pretty nearly 100% had adjuvant, and there was nothing to suggest a difference in the subsequent relapse rate. And then linked to that, and part of a very interesting program running out of the MRC trials unit in London, it was a meta-analysis of 3 trials. So Radicals, RAVES, which is a trans-Tasman oncology controlled trial presented at Astro, and a French trial, JETUG 15, which hadn't actually even reported results yet, but had shared the data with the MRC trials unit. So it was an individual patient data meta-analysis, not a pool. Yeah, so done in real time. And this is a very interesting trend, because all 3 trials showed the same thing. The adjuvant was completely it was unnecessary. Salvage was just as good, slightly different ways of doing it, but basically there was nothing to suggest it was bad. And of course the toxicity is less because you've only treated a third of the patients.
That's very reassuring, and again, it won't change the guidelines, but it will reinforce the proof we have and the level of evidence and the strengths. What we wrote, 2019, adjuvant delay relapse. That's evidence-based. All the 3 trials showed the same thing. None of the trial except one showed a survival benefit. None of the trial had a predefined salvage treatment. And we know that many of them, patients were treated with a PSA as high as 2, 3, 4, 5, whereas it's almost completely useless. All the evidence shows the same thing. So it's very reassuring to see a randomized trial, and even better to see 3 randomized trials grouped together, confirming that early adjuvant versus early salvage are equal in terms of efficacy, less toxic, and you only salvage those who are in need for salvage, and you don't need to treat everyone. So that's very reassuring.
Absolutely. And I think the positive adjuvant trial is the oldest one. A lot of it was pre-PSA, and you had to have like a palpable nodule to get salvage and stuff like that. So they were very late salvage. Whereas the subsequent ones, like the BOLA trial that was presented, the URTC one, as you say, there was a PSA benefit, but no subsequent downstream benefit. So, yeah, no, absolutely would agree with that.
That's very reassuring for guidelines. Again, when you analyze very correctly what is available, suddenly the message is a little bit different that when people say, oh, we have the strong evidence that it works. For PSA, is it so relevant?
Yeah. So I think well, the part of a sort of secondary message from that is that PSA probably isn't relevant here, because if you look at, for example, the RT01 trial, which is the UK radiotherapy dose escalation trial, but every other dose escalation trial has been the same, they all showed a benefit in PSA relapse-free survival, and no trial to date has shown even anything on metastasis, overall survival. So you trade the dose up front for a bit of hormone therapy later, but it doesn't appear to have any survival penalty or any relevance whether you PSA relapse.
What might be of major interest, I don't know if it's planned or not planned for the UK trial on adjuvant with salvage, is to stratify by risk at relapse, because we strongly suggested that many of the relapse patients don't need anything, because there's such a low PSA increase of such a long doubling time that, okay.
Absolutely. So I think the very low metastasis rate and the very good survival, I mean,
very strong signal for that.
There's certainly scope for saying, well, actually, yeah, exactly what you just said. Can we back off even further? I think the other striking thing was that 1,200 men in the trial, and it's sort of under 100 relapses each side of the thing. So with quite mature follow-up. So it shows that even patients with high-risk features mostly are not relapsing. There's only a third of them that relapsed.
That's absolutely interesting, because we had a very large cohort of patients relapsing. If I remember, it was Karim Touijer from 12,000 men. And the specific survival at 15 years was something around 85%. Okay, relapse is bad news, but you won't die the next morning. So you have to think. It's very nice to see that randomized trials reinforce what is supposed to be there.
Yeah, and I think it also reinforces the fact that the prognosis is getting better and better, and we don't need to urgently and radically over-treat people in a lot of cases. And I think there's a more general trend. I think we're giving them too much.
Exactly. We give too much local treatment for low-risk disease. We give too much treatment for relapse. Maybe we give not too much treatment for the highest risk, provided we know them. We don't give too much treatment where there are metastases.
I think the other thing we just need to say just before we wrap up, because we haven't discussed it yet, is the DNA damage repair story. So we haven't seen yet the data from the olaparib in DNA damage repair randomized trial that's going to be presented tomorrow at the presidential plenary. But there was a whole lot of stuff in the prostate discussion session today around patterns of DNA damage repair abnormality. So it looks quite likely that we're going to see a PARP inhibitor heading into the clinic with a license off the back of the olaparib data tomorrow, I suspect. So we haven't seen the data yet, but I think that's something we have to
Plenary,
anticipate.
and there was a press release on that.
Yeah, then there's a press release. So yeah, it's
New way to
publication by
communicate.
press release. Yeah,
A new way to communicate.
Yeah, you publish in the New York Times.
Yeah,
not
exactly, before
and your shareholders.
New England. Yeah.
Yes. So this is something we're going to be discussing in a lot of detail at a future meeting.
Exactly.
Yeah. So with that, I think that's probably where we wrap up. So I'd like to thank you for listening and look forward to speaking to you again at a subsequent meeting.